recording. Okay, so I didn't realize until just a few minutes ago that I had not posted the video recording of Wednesday's lecture. So I quickly put it on YouTube and uploaded it to Blackboard. Certainly by the time we are done today, it'll be available. So I do apologize that that was not done, but that is up. So your take-home exam, so next week I've been granted access to the building, so I can actually give a physical copy of your take-home exam with the answer keys. So I don't have to redo it. So I'll be posting your take-home exam online, and you can start submitting the answers. And I'll talk more about that next week. I'll also put the take-home exam. I'll push back the due date for that so it'll be the week prior to your practical. So basically, it was going to be due the week before your last practical. Since everything is being pushed back, including your practical, it'll be pushed back a week as well. And I'll update you on what the exact date of what that is next week. Let me talk a little bit about the current practical, and let me start sharing my screen. And okay, so recall that you currently have a quiz on the endocrine system. It is up and it will close tonight at midnight. So make sure you have that done. It is a quiz for mastery, meaning you can take it over and over and over again, and what will be submitted is your highest grade. Your second practical is currently open, and it will also close at midnight. Now that you can only take once. You have 42 minutes, and you're shown the questions one at a time, and you cannot backtrack. Now, with that practical, I think I somewhat gave you some wrong information about being able to see your preliminary grade. There may be a way for me to enable that. I'm not really sure, but what I'm hearing from the students who've already taken the practical is they're not able to see what their grade is per the computer. What I am doing is I'm going in and checking several times a day to see who's taking the practical, and I'm going in there and grading it myself. Certainly by tomorrow, when the practical closes, everybody will be able to see their grade. I'll send out an email and everything. Also, currently, you will not be able to see what you got right and what you got wrong. I am not allowing you to actually see the practical once you close it until the practical is done, because I don't want students talking to one another about what's on it and what they got right and all that kind of stuff while the practical is still open. Once I close it and I grade all of the practicals, I'll send out an email letting you know that it's graded and your grade is online and your overall grade for the course has been updated and all that kind of stuff. Then you'll be able to go in and you'll be able to open your practical and see what you got wrong and what you got right, and make sure that I went in, and if there was a misspelled word, that I gave you credit for it and all that kind of stuff. Okay? Once you complete the practical today, pause, celebrate, have a virtual happy hour, or whatever you currently do to let your hair down and relax, and then jump into the next labs. The pre-labs for the anatomy of the heart and the anatomy of blood vessels are already up. So it's one lab, but there are two separate pre-labs. There's a pre-lab for anatomy of the heart, and there's a pre-lab for anatomy of blood vessels, right? So you have two pre-labs that you're completing. Also, there are two separate presentations that I made. One is a presentation on the anatomy of the heart, and the second one is a presentation on the anatomy of blood vessels. Okay, those are currently available. If you go to exercise 15, anatomy of heart, and exercise 16, anatomy of blood vessels, that folder on Blackboard, you'll see the pre-lab for the heart, the presentation on the heart. Pre-lab for blood vessels, the presentation on the blood vessels. I'm going to work today and tomorrow on completing the Quizlets. So you'll have everything certainly by Monday, hopefully before that, but certainly by Monday, you'll have everything that you need to go ahead and start working on the lab material that's going to be on your next practical. Don't wait till the last minute. Don't wait till the last minute. Don't wait till the last minute. Go ahead and jump on it. When? Now. Okay, so I believe this is where we left off on Wednesday. We had talked, so we started talking about the physical characteristics of blood. We talked about the function of blood, and then we started talking about the composition of blood, that 55% of blood was plasma and 45% were the formed elements, the formed elements being red blood cells, white blood cells, and platelets. Then we talked about the components of plasma, the function of plasma, which is transportation, that plasma is 90% water and the other 10% are solutes, most of which are your plasma proteins. And we talked about the functions of those plasma proteins. Then we moved to the formed elements. More than 44% of the 45% of the formed elements are red blood cells. That only 1% of whole blood, less than 1%, is actually white blood cells and platelets. And so we started talking about red blood cells, and we said, well, the function of red blood cells is to carry oxygen, and it's designed specifically for that function. It has very few organelles. It has no nucleus, and that's to make room for the hemoglobin, which is what carries blood. Hemoglobin has a heme group or a heme component that contains iron, and that's where oxygen binds. And when oxygen binds to that iron, it emits a red color because it forms iron oxide, rust, and that's why blood is red, and that's why high oxygenated blood is a very bright red. But we said there is a trade-off for not having organelles and a nucleus, and that is red blood cells can't really repair themselves, and so they don't live very long. They only live about 115, 120 days, and that's where we are here. We also talked about hematocrit. Hematocrit is a percentage of red blood cells in whole blood, and as hematocrit increases, the oxygen carrying capacity of blood increases. As your hematocrit decreases, oxygen carrying capacity of blood decreases, and you can become anemic if it's below normal levels. And we said there are different causes of anemia. One is iron deficiency anemia. Another one could be deficiency of folate and vitamin B12, both of which are vitamins, and sickle cell anemia. All right, and that's where we left off. That's a recap of what we discussed on Wednesday. Before we move on, I want to open up the floor for any questions. Anyone have any questions at this time? Well, if there aren't any questions, we will move on talking about red blood cells. So as I said, red blood cells are basically little bags of hemoglobin. That hemoglobin binds to oxygen. For every molecule of hemoglobin can bind to 4 molecules of oxygen. There's like 250 molecules of hemoglobin in a red blood cell. So a red blood cell can carry about 1 billion molecules of oxygen. But there's a trade-off for not having a nucleus and not having many organelles. They can't repair themselves. So they don't grow, they don't divide, they don't synthesize new proteins to replace worn-out proteins, and they die somewhere between 100 and 120 days. And so they're constantly being reproduced. Worn-out red blood cells are broken down by phagocytes in the spleen and the liver, and they're replaced by new red blood cells. New red blood cells are formed from stem cells in the red bone marrow by a process called erythropoiesis. And so let's talk about that now. So here, so this is, I apologize here. I've got a very sensitive mouse here. So this cell here in the center here, I see it's not showing. my cursor, but right here in the center of the screen here is the hemocytoblast. This is a stem cell that's found in the red bone marrow. You don't have to know it by name, but just understand you have stem cells in your red bone marrow, and those stem cells give rise to all of your blood cells, including red blood cells. So you have lots of these stem cells in your red bone marrow. They make more stem cells, and then they also make all of these different cells, including erythrocytes. Those hemocytoblast cells become myeloid stem cells, which can then become erythrocytes. And that process is called erythropoiesis, production of new red blood cells. When a stem cell becomes a red blood cell, it is a complete cell. It does contain a nucleus and all of the normal organelles that you would expect to see in a complete cell. And it immediately begins to start making hemoglobin. So at that point, yeah, it has a nucleus and has ribosomes and it has rough endoplasmic reticulum. Eventually, as the nucleus fills with hemoglobin, as the cytoplasm fills with hemoglobin, the nucleus and most of the organelles are ejected. We still have rough endoplasmic reticulum with the associated ribosomes making hemoglobin. And at that time, this sort of immature red blood cell, also called a reticulocyte, leaves the red bone marrow and enters the bloodstream. And then over the next couple of days, eventually, as the cytoplasm is completely filled with hemoglobin, that endoplasmic reticulum is ejected, and now we have a mature red blood cell capable of holding about 1 billion molecules of oxygen. And this process takes about 3 to 5 days. And it's continually occurring as new red blood cells are needed to replace old red blood cells. The rate at which your red blood cells are formed by erythropoiesis is controlled by a hormone, and that hormone is erythropoietin. So the process of red blood cell formation is called erythropoiesis. The hormone that stimulates that process or increases that process is erythropoietin. That hormone is produced by the kidneys, and the stimulus for release of that hormone is a reduction in oxygen levels. So if for some reason oxygen levels are reduced in your blood, it stimulates the kidneys to produce erythropoietin. That erythropoietin targets the red bone marrow to produce more red blood cells. And so as red blood cell count increases, oxygen levels should increase, and that feeds back onto the kidney, causing a reduction in the release of erythropoietin. And this is the image from your book that illustrates this. So we have our teeter-totter up here illustrating normal oxygen levels. Let's say for some reason there's a drop in oxygen levels in the body. Let's say all of us went to see the Packers play at Mile High Stadium in Denver, right, which is about 5,000 feet higher than where we are now. So the partial pressure of oxygen is going to be lower. So when we go, there's going to be a reduction in the oxygen content of our blood. That's going to stimulate the kidneys to release erythropoietin. That erythropoietin is going to stimulate the red bone marrow to increase production of red blood cells. As the hematocrit of our blood increases, or percent red blood cell content increases, that's going to increase the oxygen carrying capacity of our blood and restore oxygen levels to normal. With our blood now at normal oxygen levels, the stimulus that caused the kidneys to release that erythropoietin is gone. So there's a reduction in further release of erythropoietin. That is how erythropoiesis, or red blood cell production, is increased in times that's how the appropriate levels of red blood cells are maintained in our blood. As oxygen levels drop in our blood, there's an increase in red blood cell production. Okay, let's talk about a couple of terms that have to do with the amount of red blood cells in whole blood. Polycythemia is above the normal amount of red blood cells in whole blood. Now, I put normal in quotes because what's normal really is dependent on certain conditions. Certainly, if you live at high altitude, like again, Denver versus here, or at an even higher altitude, because the partial pressure of oxygen is lower, you're going to have a higher red blood cell count. And so for here, the hematocrit might be above normal, but for that altitude, that might be quote unquote normal. If you have cancer of the bone marrow, you could be producing a huge number of red blood cells. That could cause polycythemia. And if you had impaired lung function, say if you had chronic bronchitis or you had emphysema, because your lungs did not oxygenate your blood as it normally would, that could cause an elevation in red blood cell count as your body is trying to compensate for the insufficiency of your lungs. So those are examples of polycythemia. Before we move on to white blood cells, I want to stop and ask if there are any questions at this time. Keep your questions specific to the content. Any other questions I'll address at the end of class. No questions? All righty, well, we will move on to white blood cells. Oh, here's a question. So if one had damage to if one had damage to a lung, would you possibly have a higher blood cell count? Possibly. It really depends on the extent of that damage. It would depend on, to what extent it impaired the ability of your lungs to oxygenate your blood. If it was extensive, then it's possible. I don't have enough knowledge to tell you, like if you had only half of your left lung functioning, right? Would that lead to a higher red blood cell count? That I do not know. I don't know what extent of damage would cause compensation by your by red blood cells, but it is possible. You're very welcome. One thing you might do is, if you've had labs done recently, is to, or over time, to check and see, hey, where does your red blood cell count actually typically run, right? And look at what's the normal range, because usually on those printouts, lab results, they'll have your numbers and they'll have like what the normal range is. And what would be really interesting would be if you can go far enough back and see what were your levels before you had that damage, if you have access to records that far back. Okay, let's now talk about the leukocytes. The leukocytes are your white blood cells. The first thing we're going to do is contrast the anatomy of leukocytes with erythrocytes and the physiology of leukocytes with erythrocytes. We're going to define what our abnormal leukocyte levels are called, as well as define different types of leukocytes or white blood cells. So your white blood cells are crucial to the body's defense against foreign microorganisms. Unlike the erythrocytes, these are complete cells, even when they're mature. They have a nucleus, they have a full complement of organelles. Also, unlike red blood cells, which can't move on their own, they pretty much just float around in the bloodstream, carried by the blood. White blood cells can move by this amoeboid motion, almost like they sort of remind me of like the blob, the way they move around. It's a process called diapedesis. So in this figure here, someone has like stepped on a nail, and by stepping on the nail, they opened up a fissure in the skin, which has allowed microorganisms to enter. Those microorganisms entering cause cells in the area of that damage to emit chemicals. It's sort of like how cells dial 911, and that's going to cause inflammation in the area of nearby blood vessels, causing them to become leaky, and substances released by those damaged cells sort of attract the white blood cells. So the white blood cells actually come out of the blood vessels and move by that amoeboid movement, that diapedesis, and they home in on those released chemicals. And that process actually is called positive chemotaxis, the ability to sort of home in on those chemicals that were released by the damaged cells. And again, you can think of that those chemicals being released are sort of like how a cell of your body dials 911. It says, hey, we've got damage here, we've got microorganism here, help. And here comes the white blood cells. So those white blood cells can literally leave the blood vessels on their own and move through tissues. There is a normal range of white blood cells in the blood, and I share these numbers with you, but in no way do you have to know them, or will I ask you for them. I figured if you need this for your programs, you'll learn it in your programs. Just know there is a normal range, and it's quite wide, somewhere between 4 and 11,000 cells per milliliter. Abnormal leukocyte levels, if they're are considered out of this range, leukocytosis is an above normal level of leukocytes, and that indicates infection. Typically that indicates infection. In response to an infection by a microorganism, there's an increase in production of leukocytes, blood cells. Leukopenia is the opposite. It's an abnormally low leukocyte level. What might cause that? Well, there are certain drugs, certain chemotherapies that will decrease the production of white blood cells, and that can cause a reduction in a reduction in your white blood cell count below normal. Corticosteroids. Remember, we mentioned that if you were under stress for a prolonged period of time, it can actually increase your infectivity or increase your likelihood of getting sick. And that's because corticosteroids like cortisol can literally decrease the production of white blood cells. Okay, another a specific abnormal leukocyte level is referred to as leukemia. It's when you have cancer of the bone marrow. Now with leukemia, what you have is an abnormally high number of white blood cells. However, they are immature. They are not competent. They're not immunocompetent, meaning that they're there, but they don't really fight infection. And so that sets the patient up for secondary infections and makes them susceptible to microorganisms that normally they could easily fight off. So someone with leukemia, what you see is a very thick, buffy coat. So they have a high blood cell count, very high blood cell count in their whole blood, but those white blood cells are not immunocompetent. They don't fight infection as they normally would. Okay, I think I heard that there was a question, so I'll stop for just a second. Yes, AIDS will also decrease your leukocyte count, and I'll mention briefly specifically the cell or type of cell that the HIV virus affects. Okay, so I'm going to talk very, very briefly about the different leukocytes. I only want you to know a bare bones sort of description of these white blood cells, and that's because on your take-home exam, which includes the lymphatic system and the immune system, you're going to get into greater detail. So for the purposes of this chapter, just a bare bones sort of description of these different types of white blood cells. And we're going to start with the granulocytes. And they're called the granulocytes because they have little granules. They're actually lysosomes that stain under the microscope. So when you look at them under the microscope, you see all these little granules, and you also see these lobed nuclei. If you see, they have multiple nuclei, and they're sort of attached to one another, and they by these sort of thin lobes. Okay? I call the granulocytes the fils because three types all end in fils: basophils, eosinophils, and neutrophils. Neutrophils are the most common white blood cell that you'll find in blood. When you look under at a blood smear under the microscope and you see those white blood cells, most of what you're looking at are neutrophils. Neutrophils are phagocytes. They phagocytize, they sort of roam around the body, and when they find a foreign microorganism or a component of that microorganism, they take it in through a phagocytotic vesicle. The lysosomes come in and digest it away, right? They're like your first line of defense against microorganisms that get through your skin. Eosinophils are involved in allergic responses, and they also are involved in mounting defenses against parasitic worms like pinworms or hookworms or trichina, that sort of thing. When I think of worms infesting the body, I think of so I remember eosinophils are the white blood cells that mount a defense against those nasty little parasitic worms. Basophils release histamine. Histamine is like a chemical alarm. It initiates inflammation by causing nearby blood vessels to become leaky. Histamine is also released in allergic reactions, and that's why many of us antihistamines to reduce the pain and inflammation that are associated with allergies, and sometimes even with actual damage to the body, like hitting your head and that sort of thing. So those were the granulocytes. Now let's move to the agranulocytes. A meaning no. So notice that in these, there aren't any little granules that stain dark. And there's two types. We have the lymphocytes and we have the monocytes. The lymphocytes are your immune cells. These are your B and your T cells. B cells produce antibodies. T cells work with the B cells to produce antibodies. And one of those T cells is called a T helper cell. That is the cell that is attacked by the HIV virus. So people who have HIV, particularly if it's not under control, they'll have very low T helper cell levels or numbers. That's what they'll. In fact, if you're trying to sort of assess, does someone have HIV positive versus do they have AIDS, when that helper T cell level drops below a certain level, they're considered to have AIDS. Lastly are the monocytes. So the monocytes are the largest of the white blood cells, and I'm talking large in terms of size. Monocytes are produced in the red bone marrow, and then they migrate to different parts of the body, and they sort of set up residence in those parts of the body. So you'll have some that'll migrate to your lungs, and then they'll set up residence there, or others that'll migrate to your liver, and they'll set up residence there, and they'll stay there almost like sentries patrolling that part of the body, and they will become a very aggressive phagocyte called a macrophage. And a macrophage is like little eating machines. They're very important for fighting chronic infections. So they become alive when you're fighting an infection that persists for a period of time, like tuberculosis. You have macrophages in your lungs that are responsible for gobbling up any little nasties that make it to your lungs. You also have macrophages in your liver to destroy some microorganisms that might enter your body through your digestive tract, because as you'll learn next in our next chapter, that blood from your digestive tract goes to your liver first. One, so the liver can process the nutrients that have been absorbed, so they can, two, detoxify substances that potentially could harm the body, and also any microorganisms that also have entered the blood through your digestive tract. The liver has macrophages to destroy them before that blood then moves to the systemic circulation and goes all over the body. So monocytes and macrophages, very, very important for fighting chronic infection and keeping the and protecting the body from microorganisms. So what stimulates the production of white blood cells by the red bone marrow? Well, for red blood cells, it was erythropoietin. For the white blood cells, it's the substance called colony stimulating factors, and actually and interleukins. And I don't want to go into great detail about how that occurs because it's really beyond the scope of this course. But these are the chemicals that stimulate production of leukocytes, and some of what causes this would be, the presence of microorganisms, which then leads to the production of these different substances to stimulate the production of these leukocytes. Okay, any questions before we leave white blood cells? Again, be familiar with the terms leukocytes and erythrocytes. You can answer red blood cell and white blood cell, but if you read the terms erythrocyte or leukocyte, you are expected to know what they are. All right, we're going to continue then if there are no questions. We're now going to talk about platelets and hemostasis. So we're going to define a platelet. We're going to explain the process of hemostasis. We're going to define a thrombosis and an embolus. And then we're going to define some bleeding disorders. So platelets are not actually cells. They are particles of this very large, sort of weird looking cell called a megakaryocyte. And I have an image of one down here at the bottom of your screen, and I stole this image off the web with a platelet with a megakaryocyte with platelets coming off of it next to a red blood cell. So you can just see how massively large that megakaryocyte is. That megakaryocyte produces little particles of itself, or I guess I should say little pieces of itself, sort of cleave off, and that's what forms these platelets. And platelets are necessary for blood clotting, which we're going to talk about in just a moment. And there is what's considered a normal platelet count. And again, I want you to know that there's a normal level of platelets that should be in your blood, but I don't expect you to remember this number. The substance thrombopoietin is the hormone or hormone-like substance. I don't actually think it's called considered a hormone that accelerates the production of platelets. platelets are involved in the process of hemostasis. Hemostasis is the stoppage of blood. Why would you want blood to stop flowing? Well, if you ruptured a blood vessel, you would want to minimize how much blood left through that rupture in that blood vessel. So you would, in that case, want blood to stop flowing through the area of injury. And so that's where platelets come in and initiate the process of hemostasis. So let's look at hemostasis. And hemostasis involves three processes. The first is vascular spasms. The second is platelet plug formation. And the third is coagulation. I used to have a video I could access that did a really good job of showing all three of these processes, but unfortunately that video was made unavailable, and I haven't been able to find it or find a suitable substitute. But let's move on to the next slides, and I'm going to explain vascular spasms, platelet plug formation, and coagulation. All right, so this image here from your book, this figure from your book, basically illustrates the processes involved in the process of forming a blood clot. So here we have step one, there's injury to this blood vessel. The very first thing that happens is we have smooth muscle in the wall of that blood vessel contracting, what's referred to as a vascular spasm. When those smooth muscles contract, it's going to cause vasoconstriction, that the size of the lumen of that blood vessel is going to get smaller, and that's going to decrease the blood that flows through. That's going to reduce the loss of blood through that rupture. Also, there is a release of the release of a substance called serotonin. That's going to stimulate pain receptors, and it's going to also reinforce the contraction of those smooth muscles. In addition to vascular spasms, the second process that occurs is what's called the formation of a platelet plug. So there are platelets that are obviously in the blood, and they don't normally adhere to the wall of a blood vessel. But with that rupture or break in the wall of the blood vessel, there are going to be collagen fibers exposed. And those collagen fibers are sticky to the platelets. So platelets that are going by, or I should say sort of floating by, will start sticking to those collagen fibers. And as they stick to those collagen fibers, they'll go through this process which is called degranulation, where they will release other chemicals. And those other chemicals will attract other platelets to the area of damage. And then they'll stick to those platelets that are to the collagen fibers, and then they'll release chemicals. They'll attract other platelets. So you'll get these platelets sticking to one another, one on top of the other. And basically what you have is a positive feedback mechanism. As one platelet is attracted to another platelet, and then it releases chemicals that attracts other platelets, so forth and so on. And you get this pile of platelets piled onto the area of damage and the formation of what's called a platelet plug. That's the second process. After we have this platelet plug, then we have quite a few reactions occurring that are honestly beyond the scope of this class, but it involves vitamin K, it involves calcium, and what you get are, do you remember the plasma protein fibrinogen? I mentioned it. I said it's involved in blood clotting, right? You have albumin, you have globulin, and you have fibrinogen. Those are the three plasma proteins. Fibrinogen is a plasma protein that is in the plasma, obviously, but you can't see it because it's soluble. In the formation of a platelet plug, substances are released that end up converting that fibrinogen to fibrin. Fibrin is not soluble in plasma, and so it falls out of solution, and it forms this fibrin meshwork, almost like a net, around the platelet plug. And that net begins to contract, and it traps red blood cells, other platelets, and so you get the formation of this like net or mesh that traps red blood cells. And that, in essence, is what forms a blood clot. That fibrin forms from fibrinogen, and it forms like a little net, a little mesh that then traps other red blood cells, and you get that blood clot forming there. A blood clot, by the way, is like a temporary patch. The purpose is to stop bleeding temporarily until new cells can be formed to replace the old cells that are damaged. So a blood clot's sort of like a temporary patch on a pipe. So if you have a pipe that ruptures and you have water coming out of the pipe, right, it might be a couple of days or so many hours before a plumber can come and replace the pipe. So you put something on it to patch it up temporarily so you don't have water spewing everywhere and, you know, and causing damage to your apartment or your house. Blood clot sort of has a similar function. It's a temporary patch into new cells can be made to replace the old cells, and that could take, you know, days to weeks. Blood clotting normally occurs somewhere between 3 and 6 minutes. Of course, that's going to depend on the extent of the damage, and if what was ruptured was a vein, which is under low pressure, versus an artery, which is under high pressure. And as I said, that blood clot is simply a temporary patch until that layer of endothelial tissue is replaced. After that, the old blood clot is actually broken down. So a clot normally only forms if there is damage to a blood vessel. But as I'm sure you know, sometimes you get abnormal or undesirable formation of a blood clot. And that is what is referred to as a thrombus. If you have, for some reason, turbulent flow of blood in a blood vessel, maybe there's damage to the lining of a blood vessel, and so you don't have the nice smooth flowing of blood across it, but you have turbulent flow, almost like water in a stream that's filled with rocks. That can initiate a blood clot, and you get the production of a thrombus. The issue, so that causes two potential problems. One is if that thrombus will block the flow of blood through the blood vessel, and if it grows to a significant size, it can completely prevent blood flow through that blood vessel. What's typically more of an issue is the fact that part of that blood clot can break off and float freely in the blood vessel, and that's what an embolus was. And that blood clot, that embolus rather, can make its way downstream and lodge in a blood vessel of the brain, causing a cerebrovascular accident or a stroke. It can lodge in the arteries of the lung, causing a pulmonary embolism, which could compromise the ability of the lungs to oxygenate the blood, or it could lodge in a coronary artery, causing a heart attack. Some individuals are prone to blood clots. My father, I learned last week, or I guess it was like 2 weeks ago, came down with a blood clot. And several months back, they found several clots in his lungs. And so he was put on an anticoagulant to break up those clots and prevent the formation of new clots. And there are quite a few drugs that are anticoagulants. Some, of course, are stronger than others. Aspirin and ibuprofen are over-the-counter drugs, of course, that we use all the time, but they are also anticoagulants. They can increase, they won't stop typically the formation of a blood clot, but they can increase clotting times. That's why typically if you're going to have any kind of surgeries or anything done, they'll ask you to make sure for so many hours or so many days you haven't had any aspirin or ibuprofen before the surgeries. Some more potent anticoagulants are like heparin and Dimacol. These typically would be administered if someone had some blood clots form in their body, and this is as a treatment to break up those clots and or prevent further clots. A bleeding disorder is, so a couple of bleeding disorders I want to talk about include thrombocytopenia. Thrombocytopenia is where there's a platelet deficiency for whatever reason, could be due to a nutrient deficiency. Platelet levels aren't normal, and this can cause what's called little pinpoint bruising, where patients can get little bruises on their skin that's very superficial that look that are like the size of a pin. And if they are actually injured, like let's say you hit your hand or something, and usually maybe you'd get a bruise about the size of a dime, but you get a bruise about the size of a $50 because it just takes longer for the clotting process to occur due to the platelet deficiency. A specific bleeding disorder is hemophilia. And hemophilia is a hereditary disorder where some of the normal proteins involved in clotting are missing. And so there's an inability for the blood to clot. And without appropriate health care, someone with hemophilia, they can literally die from a small cut that just never clots. And a small cut that normally most people wouldn't think twice about, but it actually is life-threatening to them. And typically what would treat how this would be treated would they'd get a transfusion of plasma containing the clotting factors from a normal individual. Okay, so I only have 2 minutes, and that's really not enough time to really start discussing blood groups and blood typing. So I'm going to save that for Monday's lecture. So we're gonna finish chapter 10 on blood on Monday, and then we'll immediately move into chapter 11, which is the cardiovascular system. Happy Friday to everyone. Thank you for attending. Have a great weekend. Don't forget your endocrine system quiz is up and will close at midnight, and your practical 2 is up and will close at midnight. And after you finish your practical, go ahead and start on the material for your next lab. Okay, I'll be here for at least another 10 minutes. So if you have any questions, please, about anything, please feel free to ask them at this time. So the question, can a thrombus or embolus cause an aneurysm? So what I would say is I don't know if they would necessarily cause an aneurysm, but I think they could exacerbate, that is, make an aneurysm worse. So an aneurysm is a weakening in the walls of a blood vessel. And so let's say right downstream from that weakening, there was a blood clot forming. And so it caused a reduction in the size of the lumen, which would then cause the blood to sort of back up. where that aneurysm is, and that would increase the pressure there. And so I think it could definitely exacerbate an aneurysm. Now that I think about that, why could that, I guess that could cause an aneurysm. It could, that probably could cause an aneurysm. It certainly could exacerbate an aneurysm. But now that you think about it, why couldn't it actually cause it? So I'm doing a little checking. Oh, I don't have it in it. Let me look here. All right, causes of aneurysm. So with cardiovascular disease, so it's hard for me to say that a blood clot on its own would necessarily cause an aneurysm. But, and let me see if I can share this with you. All right, so I assume you're seeing this with me, so I can get off this thing. Oh no. All right, so I assume you're seeing this with me under what can cause an aneurysm. Atherosclerotic lesions. That's basically where you have fatty deposits on the walls of a blood vessel. But what you also have associated with those fatty deposits often are blood clots. High blood pressure certainly can weaken the walls of a blood vessel and cause an aneurysm. But see, blood clots are associated with atherosclerotic lesions. They're associated with high blood pressure. It's difficult for me to say that, a blood clot on its own would necessarily cause an aneurysm, but it's as part of a syndrome or multiple changes, including blood clots, certainly could lead to aneurysm. I had an uncle who had an aortic aneurysm, and he had had multiple heart attacks that he didn't even realize he had. Probably due to the formation of those atherosclerotic plaques, probably due to some, I don't think they ever actually found any blood clots, but just because they didn't find any doesn't mean that he never had any. So an aneurysm might form, I guess what I'm saying is a blood clot might play some role in the formation, or certainly in exacerbating, making worse, an aneurysm. You're very welcome. Sorry, it's unfortunate. I don't have a lot of pathophysiology background, so I sort of learn alongside my students whenever you ask a clinical question. Come on, where's that? So this is the kind of aneurysm that my uncle had. So my understanding is that blood should be sterile. You should not have microorganisms in your blood. And in general, it is a bad sign. However, in talking with a microbiologist, and there are different terms that they use or whatever, and that having certain microorganisms for a short period of time in the blood is not necessarily a bad thing. There are certain events that can happen, such as after um, maybe there's some microorganisms that are absorbed along with nutrients from your digestive tract that might be seen in the blood for a short period of time, but they should eventually be cleared by the lymphatic system, um, and and then they shouldn't be there anymore. But if they persist, then supposedly that is uh, is a negative sign. But again, you're getting to the limits of my knowledge. Is it bacteremia? Bacteremia versus septicemia, right? Like bacteremia, okay. Septicemia, bad. Well, I thought this would be a little easier, but not so much. Which, and that would make sense, Emily, because my understanding is it should be cleared out by a certain period of time, and if then it persists, then you're in a situation that sounds like what you described, which is where the immune system can't keep up. Said Bacteremia, am I spelling Bassa? I don't know how you spell that. Bacteremia versus septicemia. Well, not the website I was looking for, but yeah, like you said, when you brush your teeth. However, sepsis is a clinical condition involving bacteria in the blood as well, which is commonly confused. However, sepsis is also a clinical component that involves inflammation of the body and a range of other symptoms such as fever, confusion, rapid breathing. Okay, so it's includes a whole syndrome. Oh, the things we got. Long-term residents. You're talking about the bacteremia. It's just you and I on here now, so if you want to unmute your mic, I think that'd be fine.
Can you hear me? Got a little chirping. Well, I was just thinking like how the gut has E. coli that lives there and doesn't make you sick and makes you vitamin D. I was just wondering if if you get blood and you put it on a slide and you see bacteria, is that always a bad thing, or is there like stuff that just lives in there and just chills?
I don't think I don't think you have resident, um, microflora and fauna in your blood. I think under certain situations, like brushing your teeth,
Hmm.
it's there for a short period of time.
Yes, definitely in my teeth because I always end up scraping my gums and bleeding.
Yep, yep. And like, let's say you had, a sore somewhere in your gut. You're going to have, even though there's lymphatic tissue that is associated with the walls of your gut to reduce that.
Hmm.
And then your liver also has macrophages that are responsible for destroying bacteria and other microorganisms that enter your bloodstream through your gut. But after an event like brushing your teeth or you know um, uh, damage to the walls of your GI tract, right? There might be some, you may see a rise in certain bacteria in your bloodstream, but my understanding is that should be that shouldn't persist. Like it should come and then go.
Yeah.
Um,
I just recently learned that about the CNS and how it's totally sterile, and if anything's in there, it's bad, which makes sense. Like if your cerebral spinal fluid has bacteria in it, bad.
yeah,
Really
well, yeah,
bad.
can produce toxins that
Mhm.
can damage brain cells.
Something I don't understand is why the inflammatory response is often leads to more damage, not less. You know what I mean?
Yeah,
Like, what why wouldn't like there be an evolutionary pressure against the inflammation being so dramatic?
right. I guess I have wondered the same thing. Um, and I guess it's the imperfection of, well, you've got two choices. It's either the brake or the gas. And
Hmm.
sometimes and if there's too much of the brake,
Yeah.
um,
There should be
Well,
there should
I
be some, like, safety mechanism, you know?
yeah. Well, yeah, I mean, even when you think about this, so I guess what I'm saying is it's like, it's from an evolutionary standpoint, I guess there's not a lot of nuance. And so
Yeah.
it's like, well, if we don't have inflammation in this response, you're gonna die,
Yeah.
right? If you have it, there's at least a chance you're gonna live.
Yeah.
Because even when you think of the fact that you don't feel well,
Mhm.
just the fact that you're not feeling well, which is somewhat supposed to tell you that there's something wrong, that can cause you, just by not feeling well, to stop drinking and then cause dehydration,
Yeah.
then causes shock and death.
Yeah. Yeah,
Uh,
yeah, we learned about what was it? What's that disease that just constant diarrhea, rice water stools, cholera, cholera.
oh,
And
yeah,
basically, it's your body is trying to defend itself, and it defends itself so efficiently that if you don't give them intravenous fluids, they just desiccate and die.
so and some of the problem with cholera becomes sort of a vicious cycle, because
Yeah.
typically what happens is
And you
someone,
get thirsty, so you want to drink more of the water, which is
right, so they go and
cholera.
they get water from the river,
Yeah.
which has the cholera bacteria in it. Then they drink it. Then they get the diarrhea. Well, what do? They go to the river
Yeah.
to relieve themselves, right? And then
Yeah.
if they drink more, they just end up
It's not
like,
fair.
yeah. So,
Yeah.
but yeah, there was a good video that I looked at online that showed that whole process and how to disrupt the cycle and everything. It was really, really cool, because I didn't understand what cholera actually was until I watched that. And I was like, oh, okay, this makes perfectly good sense. And it showed how you can boil the water for like 5 minutes or something like that, and it'll kill the bacteria, or how you can chlorinate it. And then
Oh.
and that's all you have to do. All right. It just wanted, I think it was boil it for, it may have been 10 minutes. I can't remember, but you didn't have to boil it forever. You can just boil the water for a certain amount of time before you drink it, or you chlorinate it. And that's
Yeah.
it.
Yeah,
But
the Russians
really,
have to rehydrate people, and they have a powder that you can with electrolytes and replacement, nutrients that they can put in water. But where do you get the water? Like in Haiti when there was a hurricane, was it Katrina? Yeah, there was a huge cholera epidemic, and they couldn't find clean water because I think the hurricane broke open the sewers and it contaminated the drinking water or something.
yeah. Well, you'll have bathroom facilities. So what happens? Someone goes and they defecate in the water that other people were then drinking.
Yeah.
Um, so there was this cholera epidemic in Southeast Asia, I believe,
Mhm.
years ago, and what happened was you had this cholera outbreak upriver, and people were defecating in the river, and then it was going down to the next community.
Oh, oh,
They were
fun.
drinking the water, and then they started doing the same thing, and it just spread.
That happened to me a lot in St. Louis because we were getting our water from the Mississippi, and places up the Mississippi were kept having, sewer breaks, and where their sewer was poisoning the Missis untreated sewage was going to the Mississippi, and then we're all going, oh, should we be drinking our water upstream from us? Yeah.